Hi. Hi, Professor Tanlap. Hi, Professor Kazandak. How are you today?
Yeah, it's a great day. Thank you.
Nice to meet you all. Nice to meet you all. Sorry, I'm in my actually apron because I'm working at this time.
I see. I understand. This is the last panel of the meeting, and not last but not the least, I think endodontic emergencies is one of the hot topics of the endodontic cases, and Department of Endodontics is the first department who faces the 90% of the emergencies in dental world, I think. So this is a blessed panel, I believe.
Yeah, I do agree with you. I believe most of the time, the patients, when they suffer from pain, they always think about endodontic department rather than others. And speaking about the pain as an emergency, usually end up with something like knowing about the mediators, a lot of theory behind it, sometimes very boring for
I cannot hear you, Dr. Necrotic. Is it a problem regarding to my system? Is there anyone else who cannot hear?
I think he has lost his connection.
Okay. While we're waiting, maybe I can spend a few words. Is my voice to clear everyone?
Yes, Dr. Meric. Thank you.
Yes, I would like to say hello to all colleagues here. It's a great pleasure to be with you, Professor Meric and other colleagues, Professor Tanlap and Professor Elif. It's really a great pleasure to be with you here, and it's a great time actually. I'm really enjoying my time here right now.
Thank you very much. Then, meanwhile, we're waiting for Dr. Necrotic to be reconnected again. I would like to spend a few words.
I think the problem is solved now.
That's okay. Okay, Dr. Necrotic, we're waiting for you. We cannot hear you.
Yeah. Okay. Thank you very much, all. Sorry about for some reason I'm disconnected, so I'm connecting now with my mobile phone to make sure that I'm still there. Yeah. Just as I said, I think our first lecturer today is going to speak about mediators of the pain, theory behind the pain. I personally love the theory behind the pain perception. And I think it is not possible to be a good doctor or a good dentist or a good endodontist without knowing the theory behind the pain perception. And pain perception is one of the very important topic in endodontics and in dentistry. So Professor Asadian, my colleague, who is going to speak about this topic, is going to give us a lot of information. And I really ask our student to carefully listen to him to understand very well about the theory behind the pain perception. Thank you very much, Dr. Asadian. The stage is yours.
Thank you very much, Dr. Necrotic. It's really great pleasure to speak in front of you and other great names. In the name of God, the compassionate, the merciful, I would like to start my lecture. My name is Dr. Hadi Asadian, Assistant Professor of Endodontics, Department of Endodontics from School of Dentistry, Tehran University of Medical Sciences. And the topic we're going to cover is about the underlying mechanisms of pain perception in endodontic emergency patients. First of all, when it comes to emergency cases, we have to have a clear-cut definition of what pain is. Can any of the students accompany us to answer this question, that what is the main definition of pain? Is there anybody who can help? Am I clear?
Yeah, I think you are clear, but our students should, one of them should raise their hand, and then the moderator should let them to turn on their microphone and their video and speak. So if one of the students is volunteered to answer the question from Professor Asadian, please raise their hand electronically, obviously, and then the moderator can give them the permission to speak. Okay, can you repeat, Hadi, please, the question? Oh, I think.
First of all, I would like one of the colleagues or one of the students to define what pain is.
Yeah, I think we have received some answer in the chat box. So if you look at that, you may see the answer.
I guess. I'm having.
I will try.
Okay, the first answer is, it's an unpleasant feeling, such as a prick, tingle, sting, burn, or ache. Pain may be sharp or dull. It may come and go, and it may be constant. Another answer is discomfort. Another answer is unpleasant sensory or emotional experience. And one more, activation of pain receptor. Very scientific. And uncomfortable sensation in the body. Wow, very nice. Thank you very much for the contribution.
Yes, thank you very much. Of course, we have to gather them all together in a single sentence, and that is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Of course, in case there is a tissue damage, as a sensory impulse is understood by the patient's brain, which is called pain. And it's the discomfort that alarms the patient to do something about it. Of course, this tissue damage can be actual or potential. It means that it can happen actually, or it can be at the level of a risk to cause tissue damage. Of course, it can be described in terms of such damage, and it means that sometimes it can happen without any hazard to the tissue, and it can be just felt by the patient without any underlying cause, which can be something like a phantom pain, which is not actually related to an organ. The other term, which is really important to be noticed, is an emergency. Of course, an emergency can be defined as a serious, unexpected, and often dangerous situation that requires an immediate action. In medical situations, a serious insult to the patient that can cause a life-threatening urgency or emergency needs immediate medical or sometimes dental act to overcome the situation. This is called an emergency, and this is what we are going to cover in these lectures. What we have here is actually a map that can show us the transfer of pain perception signals from periphery to the central nervous system. Of course, you can see the nerve endings coming from different teeth, which are converged in a trigeminal ganglion, and it is transferred to medullary spinal cord, and different levels of subnuclei, subnucleus polaris, subnucleus interpolaris, and subnucleus caudalis. And these pain informations is actually transmitted to higher brain levels, which is located in the cerebral cortex to understand and to define and to perceive the actual pain condition. Of course, we can have 3 levels. The first level is input or detection, which can happen by the peripheral nerves, which are located within the dental pulp. And after that, they come together in a trigeminal ganglion. Then they are processed at the medullary spinal cord and the subnuclei that I mentioned already. And then it is sensed or perceived at the level of the cortex. In any tissue, for example, in skin, if we have thermal, mechanical, chemical, or electrical insults, we can have different feelings. For example, we can have a feeling of thermal injury, for example, like burns in the skin, or in case of mechanical injury, we can understand vibration, for example, or in case of chemical insults, for example, at the tongue, we can have different tastes, for example, sour or bitter. Or in case of electrical injury, we can have some feeling like electrical vibration or some sort of gingling. But at the level of tooth nerve innervation, in case of any of these insults, we can have only pain sensation. It means that all of these conditions can result in pain perception. But it doesn't mean that all afferent nerve fibers in the dental pulp are nociceptors. They are not all nociceptors or receptors of pain condition. They can receive different stimulations from thermal, mechanical, chemical, and electrical injuries. But the definition of these insults or the perception of these insults can only be pain. Therefore, it can be necessary to classify the pulpal innervation as afferent and efferent. The afferent pulpal innervation are those nerves that transmit the signals to the brain, and the efferent innervations are those that transfer impulses from the brain to the periphery. The efferent nerve fibers are important in modulation of microcirculation, in modulation of inflammation, and in modulation of dentinogenesis. Of course, we are not going to talk about the efferent nerve fibers in this talk. The main pulpal innervation system that we're going to talk about are actually the afferents. The afferents are classified as different types according to their diameter and therefore according to their conduction velocity. The classification can be A fibers, B fibers, C fibers, and sympathetic fibers. The A fibers, of course, can have different diameters from 12 to 20, 5 to 12, 3 to 6, and 1 to 5. These nerve fibers can be classified into A alpha, A beta, A gamma, and A delta. Of course, as you can see from this table, you can understand that there are just 2 nerve classes that can transmit pain condition to the brain. One of them is A delta and the other is C fibers. Of course, the A delta fibers are also important in temperature and touch sensation, but the C fibers are only responsible for transmitting pain condition to the brain. And of course, if we go in a more detail about A delta and C fibers, the characteristics can be classified according to the following table. If we look at the following table, the A delta fibers, you can understand that the A delta fibers are myelinated, therefore the conduction velocity can be higher in comparison with C fibers. The C fibers are not myelinated, therefore the transmission of the pulpal injury stimulations can take place in a slower fashion. The location of the A delta fibers are principally in the periphery of the pulp, and of course they are near to the pulp dentin junction. But the C fibers are distributed throughout the pulp, And usually you can find even C fibers at the most apical parts of the pulp. Even if the pulp is partially necrosed, it can be found, these C fibers can be found. Therefore, in necrotic pulps, there are C fibers that are still functional, and therefore you can have pain sensation from even necrotic pulps. But the A delta fibers are usually more sensitive to tough conditions and can rapidly be destroyed. The condition of the pain which is felt by A delta fibers is usually.
Hadi, can I stop you?
Yes, sure.
I want to ask you a question because it happens in my mind about that.
Yeah.
Speaking about the C fiber and for C fiber to stay alive even when the pulp is in partial necrosis, clinically, what is the result of that?
Yes, actually in the clinic, you can find a tooth with a partial necrosis, for example, necrosis of coronal part of the pulp or the coronal 2/3 of the pulp, and only a minimal vital pulp in the apical part, but a very severe pain is felt by this pulp because of the presence of only C fibers. I don't know whether I could answer your question.
Oh, definitely, definitely. The reason that I ask you this question, just to emphasize for the students, the importance of listen very carefully to your topic, which looks all theory, but definitely they are connected to the clinic. Thank you very much, Hadi.
You're welcome. Of course, the A delta fibers, because of their location and because of their relatively low threshold of stimulation, can be involved in dental hypersensitivity reactions. For example, in case we have a very small erosion of the enamel surface or erosion of the cemental surface, in case of gingival recession, A delta fibers are usually stimulated to produce pain, and the pain is usually sharp and pricking and annoying by the patient. But the C fibers are not usually stimulated because the stimulation threshold is relatively high and is usually associated with tissue injury. And in cases of dental hypersensitivity reactions, because of mild tissue injury, you cannot have C fiber involvement. Therefore, almost all the pain conditions are felt by A delta fibers. Another important thing to talk about A delta and C fibers pain conditions is that usually in cases of C fiber activation, we can have the visceral type of pain produced. And the visceral type of pain is usually difficult to localize. But the A delta fibers are usually well localized. And therefore, in cases of dental hypersensitivity, you can say that the A delta fibers are usually involved, and the patient can exactly determine the position of the dental injury. But in case the C fiber is involved, the patient cannot differentiate the difference between maxillary or mandibular sources of pain condition. And sometimes the pain is referred to ear or neck or some other parts, which is usually as a result of C fiber activation. Because we are focusing on the emergency cases, of course, some inter-appointment pain conditions can be important, and the causes of inter-appointment pain conditions can be classified and addressed in the following slides. Of course, in case we have mechanical, chemical, microbial injury, we can have insults to the pulp and periapical regions. Of course, the more the intensity of the injury is felt, the inflammation, it can be higher, and the response is increased pain. And in case we have mechanical and chemical stimulation, which is usually associated with iatrogenic causes, and is usually associated with endodontic treatments, this can be more emphasized in detail in following slides. But the microbial causes are also important, and let's say and this is also the most important and the most common cause of dental emergencies, which can happen between endodontic sessions. That's why when we have inter-appointment pain, this can be more frequently present in cases with apical periodontitis in comparison with vital counterparts. I mean, when we have microbial causes present in the region and we start treatment in a single session, between sessions, it is sometimes it is actually more frequently seen to have an inter-appointment flare-up or inter-appointment emergency. And in cases of irreversible pulpitis, which is usually low in microbial load, the frequency of inter-appointment emergency can be diminished. Of course, the microbial causes of inter-appointment pain can be related to the mere presence of bacterial species. The more the number of bacteria, the more the feeling of pain perceived by the patient. Of course, this can be related to the virulence factors of bacteria and also the presence of the bacterial cells themselves. This can also be related to the bacterial synergism that can happen in the environment, and they help each other to have a more pronounced inflammatory response and therefore more pronounced pain perceived by the patient. Of course, the changes in the environment caused by the bacterial action, for example, release of bacterial toxins, can have an important impact on the pain perceived by the patient. And also the host resistance is very important in case of a thorough host resistance, and also a very important and a complete inflammatory response against microbial attack, we can have a more pronounced pain condition. It is also hypothesized by the literature that herpes virus infection as a co-infection or a super infection can be an important part, can play an important part in pain perception by the patient after infection. Of course, some microbial causes can be facilitated by endodontic intervention. For example, if we have an apical extrusion of debris during instrumentation, we can have a push of a large amount of bacterial load to the periapical region, and this can in turn result in increased pain perception by the patient. Sometimes we have incomplete instrumentation because of incomplete working length determination or inadequate instrumentation because of the presence of ledge formation, for example, and therefore incomplete removal of bacterial load can result in improved or increased pain perception by the patient in between the dental sessions. And the final thing can be the secondary infection. For example, in between sessions, if we have a leaky temporary restoration, we can have a secondary infection, and therefore it can result in pain perception by the patient. Or in case we do not provide our patient with an adequate coronal seal, this can result in persistent disease and secondary infection following, for example, successful endodontic initial treatment, and then this can cause pain for the patient. The non-microbial or iatrogenic causes are usually physical or chemical, but there are some factors that can influence in the pain intensity. One of them is the intensity of injury or the intensity of tissue damage that can be available after physical or chemical causes of after physical or chemical irritation through endodontic intervention. And of course, the intensity of inflammatory responses following physical or chemical attacks during iatrogenic causes can be an important factor in pain perception by the patient. All of these cases rely on the hands of inflammatory responses by the patient. So in case of physical or chemical attacks or insults during iatrogenic cases or during treatments, we can have an inflammatory response. Therefore, after the inflammatory response, we're going to have a very improved or increased sensation of pain by the patient. But there are some examples of mechanical causes. For example, if we have over-instrumentation or overextended filling after obturation, we can have increased pain perception by the patient. The factors that can influence the pain intensity can be physical tissue compression followed by over-instrumentation or overextended filling, the hygroscopic expansion of the sealers, for example, and the tissue inflammation due to laceration that can happen after instrumentation beyond the apex can also be influential. And the size of violated instrument or filling material can also be important. For example, if we over-instrument the canal with a number 35, for example, that we can have a smaller inflammatory response in comparison with a number 80, for example, 5. And of course, the size of the injury can be important, can be directly influential on the pain perceived by the patient. The main examples of chemical causes of emergency can be extruded irrigants and extruded filling materials. Of course, the factors that can influence on the pain intensity can be the toxicity of extruded material. For example, if we have extruded sealer or a sealer puff at the end of the at the apical end or within the apical periodontium, the extruded material toxicity of sealers, which is usually more felt in the first or second 24 hours, can be very influential in pain perceived by the patient. And also the volume of extruded material is important. In case of small sealer puffs, we can have minimal damage or minimal inflammatory responses. Or the bacterial superimposition, as I mentioned before, after inadequate coronal restoration. But the heart of these important factors is the inflammatory responses of the patient.
Can I have a contribution regarding your previous slide?
Pardon?
Okay, the volume of the extruded material is a very important part, I think, because the success outcome studies show that a little bit of sealer extrusion is called puff. And puff has somehow have a positive impact, although it is not statistically significant, has a even positive impact on the outcome of the endodontic treatment. So, however, volume of extruded material, if it exceeds, of course, it causes pain and it causes problem, of course, especially in case of violation of the anatomic structures, right?
Yes.
Okay, thank you very much. I just would like to put the emphasis on the clinical relationship of this.
Yes,
slide.
of course. Yes, Professor, we have a thing here. We have something to note here, and that is when we have a sealer puff, it means that we have an excellent apical seal. This is actually a sign of an excellent apical seal, which is in line with our biological goals of treatment. Therefore, if we have an adequate apical seal in the area, so we can expect favorable outcome. But of course, in short term, the toxicity of the material extruded can be annoying by the patient. It can be painful, or it can elicit pain conditions following inflammatory reactions. That is inevitable, actually.
Thank
you very much for your comments. And finally, I'm going to talk about the role of inflammatory responses in endodontic emergencies. Of course, the intensity of injury, which can have a direct impact on acute inflammation, is very important. Of course, in line with the intensity of injury that can occur, the presence of microorganisms can have a direct impact on acute inflammation. The presence of acute inflammation is a double-edged sword, which can result in repair, which can result in repair, or which can result in pain because of the tissue damage. And of course, the tissue injury can result in release of inflammatory mediators by the cells and increased excitability of nerve fibers. And in turn, it directly can result in pain. And of course, there is an indirect mechanism of pain perception because of the inflammatory mediators, because the presence of inflammatory mediators can enhance the vascular permeability, and the increased vascular permeability can have a direct impact on presence of edema, and the presence of edema can increase the hydrostatic tissue pressure, and the increased hydrostatic tissue pressure can indirectly cause physical pressure, which can cause pain. And of course, this pain can have, a very annoying, it can cause an annoying condition for the patient. In case of an intracanal infection, the chronic inflammation can occur in the periapical tissues. And of course, the presence of bacteria or addition of microorganisms into the periapical tissues, for example, through over-instrumentation or through overextended fillings after completion of the endodontic treatment, can be confronted by two layers of host defense. The first layer can be activation of the complement system through classical and alternative pathway. And the second layer can be phagocytosis by the phagocytes, I mean the neutrophils and macrophages. And of course, these two can result in release of inflammatory mediators, which are directly important in creating painful condition by the patient. And the release of inflammatory mediators can in turn cause recruitment of new phagocytes, and recruitment of new phagocytes can start another cycle of release of inflammatory mediators and can result in increased pain perception by the patient. Thank you very much for your energetic looks. Thank you very much. I hope that the information given in this lecture is helpful, and I'm here at your service for questions and answers.
Thank you very much, Dr. Asedian, for your wonderful presentation.
You're welcome.
And if you also agree, I would like to ask the questions at the end of the all presentations.
Yes, I'm here.
Okay, and I would like to give the word to Dr. Canal to give her presentation. Thank you, Dr. Asedian.
You're welcome.
Dr. Taner, you can share your screen.
Okay, can you hear me?
Yes, your voice is
Thank
clear.
you. Okay.
The topic of...
Okay, thank you very much.
Okay.
Can you see my screen?
Yes, we can see, but I think it can be better if you could make it full screen.
Okay, sure.
Thank you.
Okay, thank you very much, Professor Kazanda. I would like to take this opportunity to thank Tehran University of Medical Sciences and Yeditepe University for this wonderful organization. And I'm very privileged to take part in this series of courses. The topic of my presentation is endodontic emergencies, patient examination and diagnosis, and irreversible pulpitis. And first of all, before I start, I would like to ask two questions to the audience. The first one is 60% of symptomatic irreversible pulpitis patients also complain of A, apical swelling, B, lymphadenopathy, and C, acute apical periodontitis, D, periodontal abscess, and E, none of the above. And my second question is, in order to manage endodontic emergencies, the dental practitioner should have knowledge on A, pain mechanisms, B, patient relief, C, adequate anesthesia, D, correct diagnosis, and E, all of the above. Generally speaking, endodontic emergencies can be described as circumstances associated primarily with pain and or swelling that require immediate diagnosis and treatment. If we evaluate the incidence of endodontic emergencies is around 60 to 82% among all dental emergencies. This means that the majority of emergency cases in dentistry are related with endodontics, and we witnessed this specifically in the pandemic period. The majority of the patients presenting to the hospital complained of an endodontic emergency. So endodontics play a very significant role during that period as interventional dentistry. And if we categorize endodontic emergency cases, we can group them in three parts. The first one is pre-treatment emergencies. The second one is inter-appointment or post-treatment emergencies, which are also called flare-ups, and also iatrogenic complications. Pre-treatment emergencies are categorized in 5 groups. Acute irreversible pulpitis, acute irreversible pulpitis plus apical periodontitis, pulp necrosis without swelling, pulp necrosis with swelling, and traumatic injuries. Within this webinar, we will be talking about the first 4 cases. Traumatic injuries is a very broad concept, so it may be covered in a longer webinar. It's a entirely huge topic of its own. So the treatment of conditions in the first category and provision of patient relief are relatively more pleasing for the patient. However, inter-appointment and post-operation pain and flare-ups can be very stressful for the dental practitioner as well as the patient. And if we look at the incidence of symptomatic irreversible pulpitis, we observe that approximately 20 to 42% of the cases are irreversible symptomatic pulpitis cases. And 60% of these cases also complain of symptomatic apical periodontitis, which makes it easier to diagnose. This means that the inflammation has spread to the periodontal or periapical tissues, and most of the time we can identify the problematic tooth by percussion. It's always different than the remaining teeth. It's always more sensitive. So most of a significant amount of the cases are also related with apical periodontitis. So as a dental practitioner, our mission, our responsibility is to correctly diagnose and control the condition, gain the confidence of the patient, show attention and sympathy, which is very important while dealing with emergency cases, and treat the patient as an important individual, because most of these individuals are in high distress, and they need sympathy and attention. So we should be able to psychologically pacify and convince these people that their pain and agony will be over, will be relieved. So the goal of management of endodontic emergencies is to quickly and effectively manage pain and infections. And of course, in order to accomplish this, we should have necessary fundamental knowledge on pain mechanisms, patient relief, diagnosis, effective anesthesia, and a correct treatment strategy. So endodontic emergencies arise from factors such as pathology related with pulp tissues, pathology of periapical tissues, as well as traumatic injuries, and they require immediate attention because it affects the life quality of an individual, and necessary intervention should be made immediately. And Emergency cases in endodontics are challenging both diagnostically and therapeutically. An incorrect diagnosis not only fails to alleviate pain, but may even aggravate the existing situation, which makes it very distressful, both for the dentist and the patient. The path to follow for correct diagnosis, to reach correct diagnosis, is through subjective evaluation, some objective tests performed by the dentist, and radiographic findings. And the stimuli which trigger pain should be repeated during an objective evaluation performed by the dentist, and the patient's responses should be recorded and confirmed. For example, persistent continuous pain that aggravates with cold stimulus and mastication is generally indicative of irreversible pulpitis and symptomatic apical periodontitis. So the order by which we should proceed is, first of all, if a patient calls up for an emergency, there are some questions that we can ask the patient to understand the severity and seriousness of the condition. We should ask, does your problem affect your sleep, eating, working, concentration, or other daily activities? Real emergency cases significantly affect a person's life quality, and the individual may not be able to do routine procedures because he or she is in deep pain, deep agony. And we should ask, how long has this problem been bothering you? If real emergency cases are experienced generally in the last 1 or 2 days or the last couple of hours. So if an individual says he or she has been experiencing this pain for the last 6 or 7 months, that may not be actually an emergency case. And we should ask if the patient has received a painkiller and whether it has been effective. In real emergency cases, analgesics are not effective in pain control and prevention. We should definitely take the medical and dental history, and this should be signed and dated by the patient as well as initialed by the clinician to verify that all the information has been reviewed. So a good anamnesis of the patient's medical and dental history is essential to reach a correct diagnosis. And we should also be able to evaluate the emotional and mental condition of the patient, because some individuals have the tendency to exaggerate even very small problems. Each individual's threshold may differ. So as dental practitioners, we should actually serve as psychologists. Maybe we should develop the ability to capture a person's characteristic traits, whether he or she is exaggerating or whether it's real, it's a real emergency case. So these are issues that should be taken into consideration. A brief and complete medical history should definitely be recorded. This is an example of a medical history record. An important medical condition can be overlooked in an emergency case, such as a myocardial infarction. As we know, there is a concept, there is a part of pain which is called referred pain. So in some cases, the person may have a cardiac problem and it may be referred to another part, mostly lower chin and left arm. So the patient may perceive this as pain of dental origin, while in fact it is originating from the heart. So this is a very serious case, and we should be able to make the differentiation of these cases. And also, each time the patient arrives at clinic, we should ask the patient whether there has been any changes in his or her medical condition. Specifically, if the patient hasn't been seen for over a year, the medical history should be repeated because some changes may have occurred. So we should be able to repeat the medical history and write down new information if necessary. And also the clinician should evaluate a patient's response to the health questionnaire from two perspectives. The first one is the medical conditions and current medications that will necessitate altering the manner in which dental care will be provided is very important. Maybe we can add some medication or exclude some medication based on the patient's medical status or other medications the patient is receiving. And also those medical conditions that may have oral manifestations or mimic dental pathosis should be identified, as I stated before, a myocardial problem or any other type of pain that may be referred to the oral area. And also detailed questions should be asked in terms of dental history. Detailed questions should be asked about the pain that the patient is experiencing, such as the history, location, intensity, duration, type, and response to external stimuli. The chief complaint of the patient in the patient's own words is very important. So we should write down the chief complaint of the patient in the patient's own description and own words, because the reasons patients give for consulting with a clinician are often as important as the diagnostic tests performed. Their remarks are very helpful and they serve as initial important clues that will guide us to formulate a correct diagnosis. So we should definitely write there the description of their problem in the dental history. As stated by my colleague, pain is a complex physiological and psychological problem, and the pain threshold of an individual may be influenced from a variety of factors such as previous experiences, the existing anxiety levels, and also emotional status. So a number of factors influence the type of and degree of pain that the patient is experiencing. A visual analog scale is one way to receive information about the type of pain that the patient is experiencing. It's a scale starting from 0 and which goes up to 10. So we can make a general description of the type of pain patient is experiencing by showing the scale to the patient and picking a number. So this is a very helpful way to understand the type of pain. In some cases, as I stated before, the patient may be exaggerating, but still it's a universal and useful methodology that we can refer to. In symptomatic apical periodontitis, which constitutes the majority of the cases presenting for emergencies, pain developing with thermal stimuli are mostly of pulpal origin, and they are dull, throbbing, and lingering pain sensations. They are spontaneous, or they occur in response to an external stimulus, such as hot, cold, or chewing. In symptomatic apical periodontitis, the patient feels pain upon mastication or contact with the opposing tooth. And in this case, the problem is related with apical tissues. As stated previously, 60% of the symptomatic or irreversible pulpitis cases are also associated with apical periodontitis. So it's a good clue that helps us to understand that the inflammation has spread into the periapical tissues. So biting or chewing may trigger pain and aggravate the existing situation. And so here it is, 60% of the symptomatic irreversible pulpitis patients have also complained of apical periodontitis. And this is a summary of what we have been explaining so far. Endodontic emergencies comprise approximately 60 to 82% of the emergency cases, dental emergencies. 20 to 42% of these cases are associated with symptomatic irreversible pulpitis, and among these cases, 60% also complain of acute apical periodontitis, which is a very disturbing condition for the patient. And then we continue with extraoral examination. We try to understand the signs of physical limitations. We try to find out whether there is any facial asymmetry, and also we perform visual and examination and palpation examinations on the head and neck. And we try to understand whether the swelling is localized, diffuse, firm, or fluctuant. And also the cervical and submandibular lymph nodes should be palpated to understand whether there is any kind of pathology in these areas. These are some cases of diffuse swelling. Here we see patients complaining of diffuse swelling, canine space swelling, which extends to the left side of the face and involves the left eye. And in the right photograph, we see the swelling of the upper lip and the loss of definition of the nasolabial fold of the patient's left side, which is also a manifestation of early canine space infection. So this was one of my patients who also complained of diffuse swelling associated with tooth number 12, maxillary right lateral incisor. It was a dense invaginatus case, type 3 case, which got necrotic, and the infection spread into the periapical tissue. So in these cases, we should be very careful to take immediate action for patient relief. And also extraoral swelling associated with mandibular incisors, which we observed during extraoral examination. It exhibits itself in the submental or submandibular space, and infections associated with any mandibular teeth which exit the alveolar bone on the lingual and or inferior to the mylohyoid muscle attachment will be noted as swelling in the submandibular space. And also we should look for the presence of extraoral sinus tract by which drainage occurs. The infection is drained through an extraoral sinus tract, a fistula. So in this particular case, we see a sinus tract associated with tooth number 36. And here we see another extraoral fistula related with tooth number 46. And we also see the radiograph. I think this tooth was extracted, and patient complaints were resolved. And then we continue with an intraoral examination. Patients may experience difficulty in identifying the relevant tooth, which happens in most of the cases. Even I, as a dentist, suffered from endodontic pain, and I wasn't able to understand which tooth it originated from. So it's quite natural for patients to experience difficulty to show which tooth is actually hurting. So we should repeat the stimuli under clinical conditions to simulate the same sensation that the patient is feeling. If the same type of pain is not generated by applying the stimuli indicated by the patient, it is likely that the patient might be either exaggerating or the pain is referred and is originating from another spot. So thermal pus tests are useful for the identification of the problematic teeth. We can use heat or cold to find out the vitality of the tooth and also the reaction that the patient is showing upon heat or cold application. So in the right picture, we see the injectors by which we can apply heated water on the relevant tooth, and also some gutta percha sticks can be used. Heat up change up to 2 to 3 degrees may cause significant pain in teeth with irreversible pulpitis. Heat tests in pulpitis purulenta may be very helpful for diagnosis. However, these are not routine tests, and they may cause iatrogenic damage. So we should be very careful to differentiate those cases in which we can use this type of assessment or examination, because they may also be harmful. And electric pulse tests are also used in the clinics to identify the reaction of the patient to stimulus. And also percussion and palpation tests should be made to identify the periapical status. Periapical examination can be done by palpation, exerting pressure on the tooth, slight percussion using a mirror handle if the patient is complaining of pain during biting, and having the patient bite a cotton roll. And also we should definitely look for the presence of localized swelling or defective restorations, caries and fractures in intraoral examination. So we should make a thorough analysis of the intraoral area. And also periodontal examination is an indispensable part of endodontic emergency examination, because they may easily be confused with endodontic problems. The reason why we do periodontal examination in endodontic cases is to differentiate between endodontic and periodontal disease. So in the picture on the left side, a periodontal abscess may mimic acute apical abscess. In these cases, periodontal probing reveals the presence of a deep pocket. However, the suspicious tooth is vital in periodontal abscess. So this is a very important clue which shows us that the problem is not of endodontic origin, but it's periodontal. And also we may encounter vertical root fractures. In these cases, an isolated localized defect may be observed. And also in this picture, we see a periodontal abscess. You see the neighboring teeth do not have any caries or any restorations, and on vitality examination, we understand that they are vital, they are not necrotic. So this is a typical example of a periodontal abscess. So performing periodontal treatment only will resolve the problem and will prevent an unnecessary endodontic intervention. So we should definitely be able to make the differentiation between these cases. Periodontal examination, therefore, is an indispensable component of patient examination. And also some additional diagnostic tests may be used. This is a tooth sleuth, which the patient bites to understand whether there is any problem in the periapical region. We can also do this using a cotton roll. And selective anesthesia can also be used to differentiate the origin of pain. If the pain is not of odontogenic origin, any anesthesia injection to teeth does not help pain for the pain to subside. So it will not be useful to relieve the pain. We can also differentiate whether the problem is originating from the maxilla or the mandible by performing a selective anesthesia. So we start the selective anesthesia in the maxilla, and each tooth can be anesthetized by a single terminal injection. So initially, anesthesia is applied to the most distal tooth, and it's checked whether the pain has subsided after a waiting period of 2 to 3 minutes. So we start from the most distal and progress towards the mesial. So if the pain subsides, then we understand that that is the problematic tooth that we are dealing with. And in the mandible, we can't perform infiltrative anesthesia because of the thick cortical bone. So instead we can use intraligamentary anesthesia to identify the problematic tooth. So radiographs are definitely very useful tools to understand the problematic teeth, but definitely they are not the only means to identify a painful tooth. They're just some adjuncts, some supplementary methodologies that help us to make a true diagnosis. So we can take periapical or bite wing x-rays to identify interproximal caries. Bite wings are especially useful to identify interproximal caries, pulpal exposures, secondary caries, internal and external resorptions. So in the early stages of acute pulpitis, the responsible tooth may not be identified by radiography only. In some cases, there may be more than one suspicious tooth, which makes diagnosis very difficult. They may have deep fillings, deep amalgam restorations. So in the early stages, it may be very difficult to make a true correct diagnosis. So finally, our progression is identifying the problematic tooth. And if once we identify the problematic tooth, a treatment plan is made. It's either an emergency treatment, which we continue later. So it's classified in two parts. The first part is emergency treatment, and then we continue with permanent treatment. So these are some types of treatment that we can prefer to manage these cases. So patients coming for an emergency treatment suffer highly from anxiety and stress, and we should definitely reassure them that their pain will be relieved. This is the key to a successful emergency intervention. A hot tooth is a common term that is used for endodontic emergencies. It's a painful tooth, and initial therapy for it refers to what needs to be done to give relief from pain at first appointment. Before treatment is given, a diagnosis is made that whether the pain is of odontogenic or non-odontogenic origin. In some cases, there might be living nerve tissue inside the tooth, but the extent of inflammation prevents the tooth from recovery. Sometimes a hot tooth will no longer be vital, and these cases are termed necrotic. And my colleague Elif Delve Başarcan will be talking about these types of emergency cases. So let's talk a little bit about acute irreversible pulpitis, for which majority of endodontic emergencies are referred. The characteristic symptoms of this type of pathology are pain lasts for minutes to hours. It is spontaneous. It often continues even when the cause is removed. Pain is present when the patient bends over. Patient generally complains of disturbed sleep, and pain is experienced on sudden temperature changes, on taking sweets or acidic foodstuff, and also from packing of food into cavity, which is also called food impaction. So what we have to do is, because the pain is originating from the inflammation in the coronal pulp tissue, we have to remove this inflamed tissue for patient relief. And as stated previously, these cases may be accompanied by symptomatic apical periodontitis. In some cases, the inflammation hasn't actually affected the periapical area, so no apical periodontitis may be present. So if we have adequate time, the root canals should be thoroughly cleaned and shaped. If we're dealing with single-rooted teeth, most of the time we can totally remove the pulpal tissue. In multi-rooted teeth, at least the largest root canal, which is palatal in the maxillary molars and distal in the mandibular molars, should be removed to provide relief. But most of the time, we remove the entire pulp tissue to make sure that we have completely isolated the pathological pulp tissue. And also partial pulpotomy can be performed in molar teeth if there is no adequate time as an emergency intervention, and at a later date, we can complete the rest of the treatment. This is another option, but still, personally, I extirpate the entire pulp. But of course, if we don't have adequate time, and if the patient is very stressful and wants the procedure to be completed in a short time, maybe partial pulpotomy may be another option. And after root canal cleaning and sodium hypochlorite irrigation, a dry cotton pellet may be applied, and also we can prescribe a mild analgesic such as ibuprofen or paracetamol. However, in most cases, there will be no necessity of medication because the pain will be relieved because of the removal of the cause. So maybe we can tell the patient to take an ibuprofen right after the procedure, but if in case there is no further pain, the medication can be discontinued. So as I said, we can perform a partial pulpotomy, and several protocol changes have been seen over the years, and currently complete instrumentation with placement of an intracanal medicament is now the preferred choice among most endodontists. And also there has been a dramatic shift in the type of intracanal medicament. Currently, significantly greater number of endodontists use calcium hydroxide owing to its bactericidal and detoxification effect. And also we should, I should emphasize that leaving the tooth open for drainage is no longer considered beneficial, and it may have further disadvantages. So this is not an advocated, this is not a recommended method to deal with emergency cases. Prescription of antibiotics as acute irreversible pulpitis is definitely contraindicated and is of no benefit. Unfortunately, there are still practitioners who prefer this approach, but there is no point in prescribing antibiotics. The only means by which we can deal with these cases is removal of the inflamed tissue and maybe prescribe some analgesics, but antibiotics are of no use. They may cause allergic reactions, and they may also stimulate the development of resistant species. So antibiotic usage should be restricted to only a group of cases such as diffuse swelling, which my colleague will be talking about. Finally, I would like to share a case which I cited from a book by Hülsmann and Schaefer, Problems in Endodontics. I had the privilege of translating some chapters of this book to Turkish. So this is an interesting case which emphasizes the importance of correct diagnosis in endodontics and the consequences if a misdiagnosis is made. So this is a 30-year-old female patient with no systemic diseases, and 3 days ago, sorry, the patient presented to another clinic with severe pain, excuse me, with severe pain on the right side of her face. And the dentist diagnosed a periapical lesion associated with tooth number 47 and performed an endodontic intervention. This is the radiograph of tooth number 47. However, despite this attempt, the reduction of pain was only to a tolerable level. It took 2 days for the pain to come to a tolerable level by the patient. And in clinical examination, a very small endodontic excess cavity was observed in tooth number 47, and the cavity was filled with a temporary filling. So what will we think about this case? So another detail in the radiograph was a presence of a occlusal porcelain restoration, which appears to be relatively shallow before the treatment. This is the endodontic excess cavity. So it's observed that the porcelain filling was not too close to the pulp. So it can be assumed that actually this tooth was not related with the patient's problem. And also the patient reported that only a panoramic X-ray was taken before the procedure. So it is quite suspicious whether this tooth was actually the problematic one. During emergency intervention, the temporary filling was removed and a black mass was observed, and it was detected that this was a devitalizing agent applied to relieve the patient's pain. So we no longer use any devitalizing agents. They may have additional harmful effects. So this is one mistake that the dental practitioner made. These are not preferred materials nowadays. And the endodontic treatment was completed, and the patient reported that there were no longer any painful symptoms. However, after 3 weeks, the patient returned to the clinic with complaints of swelling in the palatal region of teeth numbers 14 and 15. And it was noticed that tooth number 14 gave a negative response. So an endodontic treatment was performed for tooth number 14, which was found to be necrotic. So if we think retrospectively in this case, we can speculate that the source of pain the patient experienced was actually associated with tooth number 14 instead of 47, which means that a misdiagnosis was made. If it was detected that the problem was originating from tooth number 14, which was necrotic, and actually it was being referred to the mandible, then tooth number 47 would be saved from endodontic treatment. It was just an unnecessary intervention which had no benefit at all. And so this case, one more time, emphasizes the importance of a correct diagnosis and shows us that we can easily be mistaken. Even the most experienced dental practitioner may cause mishaps or misdiagnosis. So we should, if we are not sure, maybe we should wait for a while for symptoms, to observe the symptoms, to understand whether as time passes, the symptoms subside or they get worse. So this is a very good example which shows the importance of a correct diagnosis. And finally, I would like to mention food impaction, which can easily be confused by acute irreversible pulpitis. It's a discomfort which shows itself by pressure, feeling of pressure, vague pain. Root caries might be a factor which causes this problem. It's actually a forceful edging of food into the periodontium, and also some periodontal changes may be observed, such as gingival inflammation, bleeding, and gingival recession. And finally, it causes bone loss and tooth mobility. It's a progression of events which end up with bone loss. So food impaction should be taken seriously, and it can easily be confused with irreversible pulpitis because the symptoms are quite alike. So we should definitely check the periodontium for the presence of food impaction if we are suspecting acute irreversible pulpitis. In this case, we can make a differential diagnosis by checking the tooth vitality as well. And food impaction, interestingly, may closely resemble acute irreversible pulpitis. We should be aware of this fact. And what is the treatment? Of course, periodontal treatment is essential. Scaling, root planing, flossing, interproximal brushing, and curettage are some periodontal interventions that can be performed. And a restoration should be repeated to provide an ideal contact with the neighboring tooth, and also a permanent restoration should be performed. So I finally wanted to mention this because it's also an important factor which may cause misdiagnosis. So I would like to thank you all for your kind attention, and thank you for listening to my presentation. And again, thank you very much to the organizing committee for this wonderful event, wonderful course. Your questions are always welcome.
Thank you very much, Dr. Taner and Dr. Asedian. So I would like to invite Dr. Asedian to the stage again, and for the questions from the audience about the presentations. So Dr. Asedian and Dr. Taner, you can write your questions to the chat part.
Okay, thank you very much, Jale. That was very informative, and Hadi as well, both of you. I think we already bombarded our students with a lot of information. So I hope they can digest it. Maybe they need actually to go through the recorded sessions as well and go through the details to have all this information all together. But while we are waiting for the questions, I want to add something to what we received. I will call that as the take-home message for our students. I think the most important message is to have a proper diagnosis before any intervention. I think Jalal showed you a lot of good examples of that the most important thing is diagnosis. And without diagnosis, without a proper diagnosis, we shouldn't do anything. Because if you don't have a proper diagnosis, you cannot do a proper treatment. And this is the most important thing that I learned from what, especially during the Jalal lecture, I have received that. And from Hadi's lecture, what I want to emphasize is the importance of the theory of the pain perception connected and correlated to the proper diagnosis. So without knowing enough information about the type of the nerve that we have inside the dental pulp or what is going on when we have pain, we cannot end up with a proper diagnosis. Without a proper diagnosis, we cannot give a good service to our patient. So we need to be careful about all of that. And when it goes to the treatment, my fellow young future colleagues, please listen very carefully. Without a proper diagnosis, you cannot do anything. But when you got the diagnosis, you need to get rid of the source of the problem rather than intervene with medication. I think the very nice word from Professor Tanlap was to know that we shouldn't use any causative or any irrigation or any material inside the canal without removing the source. The most important things in endodontics is to get rid of the source of the pain without doing anything else. Thank you very much, both of you. I personally learned a lot. Thank you, and it was a great pleasure moderating this session with Professor Kazandak. Thank you very much. I'm still with you.
It's my pleasure. Thank you.
Thank you. So I have a question for Dr. Asadian. During endodontic access cavity preparation, despite of the local anesthesia, there is a greater chance for the patient to feel pain when we firstly expose the dental pulp. What can be the possible reason for that?
Can you please repeat the question? I missed the last part.
During endodontic cavity preparation, despite of the anesthesia, local anesthesia, when we first access the pulp chamber, there is a greater chance for the patient to feel pain. So what can be the possible reason for that?
First of all, there is a process called hyperalgesia. You know, when there is inflammation in the region, one of the components of the inflammation in the region is hyperalgesia and the other is allodynia. The hyperalgesia has two parts: the central component of hyperalgesia and the peripheral part of hyperalgesia. The central part goes back to the central nervous system, and the central nervous system is more sensitive to perceive pain stimulation or pain impulses, and the threshold is lowered. And the peripheral arm of the hyperalgesia is because of the changes in the wall of the cells that are responsible for receiving the stimuli. And that's why, because of the lower threshold, even the vibration during the access cavity preparation or the changes in mechanical pressure that happens can have painful stimulation on the nerve endings. Or sometimes this can cause failure of anesthesia, or the local anesthetics are not actually effective. Therefore, higher doses of local anesthetics are recommended to perform a profound anesthesia for adequate and painless endodontics. Of course, this is a very complicated story because of the interplay between different inflammatory mediators that are responsible for hyperalgesia and mechanical allodynia that can occur, especially in chronically inflamed cases. And of course, there is a problem that Professor Canal addressed, and that is the hot tooth, which is usually difficult to provide adequate anesthesia. And you can understand that your anesthesia is successful. The nerves are blocked. You have the feeling of numbness in the buccal area and the lingual area, but the pulp itself is not anesthetized. And this can be because of the theory of hyperalgesia. Of course, in these cases, administration of supplementary injections, for example, interligamentary injection or intrapulpal injection can be helpful. And literature shows us evidence that even pre-medication with non-steroid anti-inflammatory drugs or NSAIDs, for example, ibuprofen or ketorolac can also be important in lowering the threshold and modifying the condition in order to have a profound anesthesia. Or administration of supplemental injection like infiltration anesthesia using, for example, articaine can be helpful in these cases. Of course, this is a very complicated case in order to establish profound anesthesia. And of course, if you provide the patient with adequate anesthesia, the rest of the procedure would be at ease.
Thank you very much.
You're welcome.
Are there any questions for Dr. Asedian from the audience? Okay. And I have thank you very much, Dr. Asedian. And I have a question for Dr. Tanay. You told us that pain is subjective, and to have a more objective insight or concrete measurement, we may use the visual analog scale to measure the pain or visualize the pain. Do you think that it is enough to use a West scale?
It's definitely very helpful, and what we also use in our clinics. However, it may also be misleading, as I stated previously, because some individuals have the tendency to exaggerate or to overscore the type of pain that they're feeling. But still, it's a good means by which we can classify real emergency cases, because in times of severe pain, people generally give correct scores. But of course, we as dentists should be able to differentiate those cases which are experiencing pain for maybe 6 or 7 months. So we can ask additional questions to understand whether it's an acute pain or it has been going on for a while and the patient finally came for treatment. But visual analog scale is a universal method that is very helpful, but it's not the only means. It has to be supplemented. It has to be supported by other diagnostic tools as well.
Thank you very much.
Okay.
So you can ask to the speakers at the end of the session as well. Due to the time constrictions, we would like to continue with the next speaker, Dr. Başarcan.
Yes, I'm here. Thank you.
You can share your screen with us.
Okay. I think I can manage to share my screen with you. Is it okay?
Yes, we can see your screen. You can go on.
Okay. Good afternoon, everyone. One more time from a sunny Sunday from Istanbul. And dear moderators, dear colleagues, and dear students, before starting my presentation, I would like to thank the organizing committee for giving me this opportunity, and it's really an honor for me to be here with you. Today we will talk about the emergency endodontic management of necrotic teeth with and without swelling. And it will be the continuation of Dr. Jale's presentation. And these are the questions for the competition. The first one is, in teeth with necrotic pulp and apical periodontitis without swelling, which of the following one is not the treatment of choice? And the second question is, which one of the following statements is not correct about the drainage of the pus in case of acute apical abscess with diffuse swelling? And after watching this presentation, you will be able to easily find the answers of these questions. Okay, let's start. Endodontic infections are caused by microbial communities and that invade periradicular tissues from root canals and produce inflammatory disease. And these microbes that have been detected in these communities are usually bacteria, spirochetes, fungi, and even viruses. Once bacteria have invaded periradicular tissues, our patient will eventually exhibit clinical signs and symptoms, and the severity of these infections and symptoms is related to the virulence of the organisms and the host resistance. In the current literature, 5 clinical presentations are considered as emergencies. As I mentioned in the beginning, we will talk about the emergency cases which has necrotic pulp tissue. Once it has been determined that endodontic treatment is necessary, and it is the responsibility of the clinician to take the proper steps to manage the acute dental emergency. And the clinician has to inform his or her patient about the recommended treatment plan and advise the treatment alternatives, the risks and benefits, and expected prognosis under the present circumstances. And given this information, the patient may elect extraction over endodontics or possibly request a second opinion. The treatment plan should never be forced on a patient, even if it is an emergency case. The clinician and the patient should decide together for the best treatment plan. When we talk about the management of pulp necrosis with apical ptosis, for a successful treatment, first we have to remove or reduce the pulp irritants from the canal, and second, we must try to relieve the apical pressure if it is possible. As a reminder, it's better to define some of the terminology about this ptosis. Abscess is a localized collection of pus within a tissue or confined space. Pus is an accumulation of purulent exudates and consists of microbes and byproducts, neutrophils, cells undergoing autolysis, and cellular contents. And cellulitis is a symptomatic oedematous inflammatory process that spreads diffusely through the connective tissue and facial planes. Our first disease is pulp necrosis with symptomatic apical periodontitis without swelling. Microbes release their toxins and byproducts into the canal system as well as into the periapical tissues. Then an inflammatory response is activated by this way, and inflammatory mediators are released, which activate osteoclasts and leading to bone resorption. And some of these lesions expand and form an abscess that is confined to the bone. And these abscesses are often painful, and this pain is usually intense because the inflammation is confined within the hard bony tissues and the periodontal ligament, where there is no space for the swelling to expand. As a typical symptom, the patient usually feels quite severe pain, which has only been present for a short time, for example, a few days or less. Also, the tooth is sensitive to, biting or pressure, and the tooth has no thermal sensitivity. Clinically, caries, restoration breaking down, or a crack may be seen. The tooth is very tender to percussion and may be tender to palpation, and no response to pulp sensibility tests. During radiographic examination, caries may be seen if extensive enough. Normal or slightly widened periodontal ligament space may be evident if the tooth is extruded from its normal position. And in some cases, a periapical lesion may be seen, indicating that a chronic apical periodontitis has been present for some time. The primary aim of the treatment is to reduce the canal irritants and try to encourage some drainage through the tooth. As an emergency treatment, after determining the correct working length, complete canal debridement is the treatment of choice. If the time is limited, partial debridement at the estimated working length can be performed with light instrumentation with a passive crown down technique or passive step back technique to reduce or remove the infected tissues from the canal. During cleaning and shaping, canals should be irrigated with copious amount of full strength sodium hypochlorite. As a final irrigation, we have to use EDTA followed by sodium hypochlorite. And after drying with paper points, calcium hydroxide paste can be used intracanal medicament. And after that, the cavity should be sealed with dry cotton pellets and the temporary restoration. The access must never be left open for drainage. And there are some important points to consider during this emergency treatment. Care should be taken not to push necrotic debris beyond the apex during root canal instrumentation, as this will promote more post-treatment discomfort. Crown down instrumentation technique have been shown to remove most of the debris coronally rather than pushing it out the apex. And the use of positive pressure irrigation methods such as needle and syringe irrigation also poses a risk of expressing debris or solution out of the apex. So we have to be careful when using these irrigation methods during the emergency treatment. Electronic apex locators could increase the accuracy in determining working length measurements, and it has been reported that final irrigation with sterile cold saline solution, which is called cryotherapy, reduced the incidence of postoperative pain and the need for medication in patients with necrotic pulp and symptomatic apical periodontitis. In this type of cases, we do not have fluctuancy, so incision and drainage is contraindicated. The only thing we can do is root canal debridement. And also the patient should be placed on hot saline rinses that will soothe the tissues and encourage more rapid movement of the inflammatory exudate through the bone into the soft tissues. And after that, the incision and drainage may be attempted. Some clinicians suggest the use of patency filing in order to obtain drainage from the apex, but this release often does not occur because the abscess cavity does not communicate directly with the apical foramen. If it is used aggressively, especially without cleaning the canal, through the passing the apical constriction may inoculate periapical tissues with undesirable bacterial species, thereby creating an even worse clinical situations. So rather than patency filing, apical trephination can be considered. Apical trephination is a perforation of the alveolar cortical plate to release from between cortical plates the accumulated inflammatory and infective tissue exudate that causes pain. And this procedure is accomplished by aggressively placing a size 15 to 25 K files 2 to 3 millimeter beyond the confines of the apex. And in most cases, this will establish drainage, and each case should have a radiographic verification of the file position beyond the apex. This procedure can introduce some treatment problems, such as destruction of the natural apical constriction or zipping of the canal at the apex, especially in curved canals. Also, in cases of acute apical pain and acute infection, obtaining profound anesthesia for surgical interventions can be difficult. But however, the benefits of the procedure may outweigh the potential problems. Actually, a surgical trephination is rarely needed to manage pain if good principles of diagnosis and treatments are followed. When apical trephination has failed or cannot be performed, severe pain, which is caused by a significant increase in intracortical pressure, can be relieved by surgical trephination. And this procedure involves a soft tissue incision, cortical penetration with a rotary instrument, and the creation of a pathway for drainage from the periradicular tissues. First, you have to administer proper anesthesia, and with a scalpel, you have to make a small vertical incision adjacent to the root of the affected teeth. And you have to retract the mucosa with a tissue retractor or white side of an wax spatula. After that, number 6 or number 8 round burrs is used to penetrate the cortical plate only. And after that, a large K file, minimum size 40 or spoon crate, is used to make a path through the cancellous bone to the periradicular tissues or lesion. And of course, you should avoid contact with the root apex. And after that, immediate drainage or relief of intracortical pressure is usually obtained by this way. And again, the patient should be advised to use warm to hot saline rinses for at least 24 hours to enhance drainage from the trephination site. Some studies have questioned the long-term prognosis of necrotic teeth, especially in cases of symptomatic apical periodontitis. Several studies of them have shown no difference in outcome between single visit and 2-visit treatments. And considerable number of studies has indicated that there may be no difference in post-treatment pain if the canals are filled at the time of the emergency treatment date or later. So if you have time, you can finish your endodontic treatment in the emergency visit. Our next disease is acute apical abscess with localized intraoral swelling. In these situations, an abscess has invaded regional soft tissues, and sometimes there is a purulent exudate in the canal. Locally, the patient may experience swelling and mild to severe pain. The infected tooth will usually be sensitive to biting, percussion, and palpation, and will not respond to any pulp sensibility tests and will exhibit varying degrees of mobility. Radiographic findings range from no periapical change to large radiolucencies. That means the tooth may or may not show radiographic evidence of periradicular disease. If a swelling is present, the clinician must determine whether the swelling is fluctuant or non-fluctuant. Sometimes we have fluctuancy and drainage through the tooth together, especially if you are in a lucky day. And once you open the tooth, drainage will obtain from the canals through the access opening. This drainage can be minimal or profuse, and in some cases, it may continue for minutes, exhibiting a pulsating type of flow. And the color of the pus is usually yellowish at the beginning of the drainage and then continue with greenish, bloody, and whitish color respectively. As an emergency treatment, the canals should be cleaned and shaped with copious irrigation of sodium hypochlorite, which will reduce the amount of necrotic tissue and bacteria. The canals are then dried with paper points and filled with calcium hydroxide paste. Occasionally, pus will continue to fill the canal during the preparation procedures, which is called as weeping canal. If this occurs, the patient may sit for some time with rubber dam, of course, in order to have full drainage from the canals. The access cavity should not be left open because a canal exposed to oral cavity is a potential home for bacteria, food debris, and even viruses, and this will lead to worse clinical situations. After obtaining drainage through the tooth, if the tissue is still turgid, I mean, if the soft tissue is still swollen, an incision and drainage can be performed, but most of the time this procedure is optional. If you decide to do incision and drainage, you have to administer additional anesthetic solutions, and you should administer it around the swollen area, not into the localized swelling. An incision can be made horizontally at the base of the swelling or vertically but it should be placed between the roots of the teeth. After that, by opening a hemostat within the fluctuant area, drainage can be encouraged from this area. If the swelling has fluctuancy but no drainage from the tooth, cleaning and shaping of the canals should be completed. Anesthetic solutions should be delivered. Incision and drainage should be performed with the same way as we talked before. Drains are not indicated in most cases because these are the localized small swellings, and the incision will remain open long enough to achieve desired result. Again, warm saline rinses are suggested for approximately 24 to 48 hours. Whether it is from the canal or from the incision site, drainage accomplishes three things: relief of pressure and pain, and secondly, removal of potent irritants, and thirdly, prevention of the spread of infection to the facial spaces. If there is no fluctuance but drainage could be achieved from the canals, then canal debridement should be performed as we mentioned before. Because the tissue is non-fluctuant, meaning that it's quite firm, there is no indication to incise and drain because this procedure would be non-productive. Again, warm saline holes as opposed to rinses may be suggested in an attempt to pull the purulence into a localized area for later incision and drainage. Usually the amount of pus and necrotic debris that exists through the root canals from the excess cavity is nominal. That means not very much, but it is usually adequate to provide relief of the patient in acute discomfort. The next disease is acute apical abscess with diffuse extraoral swellings, in other words, facial cellulitis. Facial cellulitis occurs when an infected root canal system develops a periapical abscess and the infection spreads between the facial planes of the muscles of the face, head, or neck. It's a spreading infection and it can be superficial or deep. In either case, it can be life-threatening if the swelling restricts the airway. A patient with facial swellings, facial cellulitis require immediate and aggressive treatment. That is not just oral antibiotic therapy, but active dental treatment to remove the source of the bacteria, remove the source of the infection. These patients often require hospitalization and even management in an intensive care unit to protect the airway and provide life support in severe cases. The swelling usually has rapid onset. For example, within hours, the patient has considerable pain and discomfort. The pain has only been present for a short time. There is pain to biting or pressure on the tooth, and the patient has no thermal sensitivity. Clinically, caries, restoration breakdown, cracks may be seen. The tooth is very tender to percussion, palpation, and there is no response to pulse sensibility test. Generally, the patient has fever, malaise, and lymphadenopathy, and in severe cases may have airway involvement. Radiographically, usually have a periapical radiolucency is present, indicates that a chronic periapical periodontitis has been present for some time before the abscess and facial cellulitis develop. Because the reaction occurs quickly, sometimes the involved tooth may not show radiographic evidence of a widened periodontal ligament space. Facial spaces are potential anatomic areas that exist between the fascia and underlying organs and other tissues. During infection, these spaces are formed as a result of spread of purulent exudate. The spread of infection is determined by the location of the root end of the affected tooth to its overlying buccal or lingual cortical plate and relationship of the apex to the attachment of the muscle. For example, if the source of the infection is a mandibular molar whose apices lie closer to the lingual cortical plate and above the mylohyoid muscle, The purulent exudate may break through the lingual cortical plate into the sublingual space. However, if the apices lie below the attachment of the mylohyoid muscle, the infection may spread into the submandibular space. In some cases, acute apical abscess cause life-threatening diffuse swellings, as we talked before. These patients have limiting opening, pain, and difficulty in swallowing, and occasionally bilateral spread may also occur. There may be elevated temperature or other systemic signs indicating serious infections. And fortunately, these serious infections do not occur very often. And these patients should be referred to an oral surgeon for extraoral drainage first and IV antibiotics and pain management. Often, these patients have to be hospitalized for aggressive treatment, as we mentioned before. Once stable, this patient may return for initiation of canal debridement. Most important thing is the removal of the irritant either by the canal debridement or by extraction. If endodontic treatment is preferred, after placing calcium hydroxide paste and the dry palate, the access should be closed with a temporary restoration. If the extraoral swelling is not life-threatening, and if the endodontic treatment is possible and preferred, chemomechanical preparation of the infected root canals and incision and drainage of any fluctuant periodicular swelling usually provide immediate improvement of the clinical signs and symptoms. The majority of the cases of endodontic infections can be treated effectively without the use of systemic antibiotics. The essential treatment is the removal of the cause of the inflammatory condition. If you manage to drain and chemomechanical debridement of the canal, mostly that means you do not need to use antibiotics as an additional medical treatment. Antibiotics are recommended for progressive persistent infections with systemic signs and symptoms, and for cases that incision and drainage could not be achieved. So we have to follow our patients daily to be sure that the infection is resolving. If we have prescribed antibiotics, the best practical guide for determining the duration of antibiotic therapy is the clinical improvement of the patient. When clinical evidence indicates that the infection is resolving or resolved, antibiotics should be administered for no longer than 1 or 2 days more. The incision and drainage procedure is similar with the one we talked before. Before the incision, we have to administer nerve block anesthesia, and if it is necessary, we can supplement it with local infiltration anesthesia. Except for very small localized swellings, a drain should be stored into the place. Drains may be a piece of dental dam, a Penrose drain or capillary drain, or even a piece of examination glove. A sutured drain keeps the incision open for continued drainage and encourages the patient to return for follow-up evaluations. Again, the use of warm intraoral rinses may help to promote drainage. The drain can usually be removed in 1 or 2 days when there is improvement of the patient's clinical symptoms. Needle aspiration is an alternative technique to incision for drainage. This procedure may provide information about the volume of exudate, type of fluid inside the swelling, if it is whether a cystic fluid or blood. Samples may be used for either culturing, molecular methods, or immunohistochemical analysis. If you have to administer regional or you have to administer a regional and local anesthesia before the needle aspiration technique, and this technique involves the use of a syringe with an 18-gauge needle to aspirate the contents of a swelling. And clinical advantage of needle aspiration over incision is includes reduced scarring and the lack of postoperative drain removal. I would like to talk a little bit about the use of systemic antibiotics for endodontic infections. If the patient is healthy And you can, if you can achieve root canal debridement and incision and drainage, this means you have managed to eliminate the source of the infection, and there is no need to use systemic antibiotics. You will have the immediate improvement of clinical signs and symptoms. And also there are several clinical situations which antibiotics are not recommended. These are symptomatic irreversible pulpitis, pulp necrosis, symptomatic apical periodontitis, chronic apical abscess, acute apical abscess without systemic involvement, which means localized fluctuant swellings. And as we talked before, in some serious cases, we need adjunctive systematic antibiotic treatments. These are acute apical abscess in medically compromised patients, acute apical abscess with systemic involvement. As we talked before, the patient who has elevated body temperature, malaise, lymphadenopathy, or trismus, and progressive infections, which means rapid onset of severe infections in less than 24 hours, cellulitis or spreading infection or osteomyelitis, where referral to oral surgeon may be necessary before endodontic treatment. Odontogenic infections include polymicrobial involving combination of gram-positive, gram-negative, or facultative anaerobic bacteria. And in dentistry, antibiotic prescription is empirical because the dentist does not know what microorganisms are responsible for the infection, as samples from the root canal or periapical region are not commonly taken and analyzed. Thus, the organisms responsible for the infection can only be suspected, and treatment is decided on a presumptive basis, with broad spectrum antibiotics often being prescribed. Sorry. Can you see my screen?
We cannot
can you see
it now?
Okay, I'm working on it.
Now it's back.
It is okay. Okay, thank you. Now, where's my other slides? Sorry. Can you give me a couple of?
Yes, of course. If there are any questions, meanwhile, we can accept from the audience. Yes. This is for Dr. Elif, I think. Now she's dealing with the connection problem. But after the session is over, I have noted your question. I will ask it. I would like to take this opportunity to spend a few words about this meeting. First of all, I would like to thank my dear friend, Dr. Nekofar, who came up first with the idea of organizing such a joint meeting. And also, I would like to, I see that this meeting, I happily see that this meeting helped us to serve the dental students from all over the globe, as well as our own students. And also I happily see that it served to build up new friendships between the faculty members of these two distinguished institutions. And I would like to declare here that 90% of the credit goes to Dr. Shakib, who's the Vice Dean of Dental School of Tehran University of Medical Sciences. Dr. Shakib, could you please turn on your camera? I would like to express my sincere appreciation to your continuous effort during this meeting from the very beginning, the signing of the agreement between the two universities and preparing the booklet, establishing the social web pages, and also the for organizing the many pre-congress meetings, I believe, which all served to this meeting to be held in such a perfect way. Thank you very much.
It's very kind of you, Professor Meric. It's my pleasure to be in touch with you and our colleagues in Yeditepe University. If you would let us, let's listen to the remaining of the presentation of Dr. Elif, and we will talk at the end about the details of the program. Thank you for your kind words.
Yes, of course. I think Dr. Elif is ready already.
Yes, I am. I lost my last two slides. It's unbelievable. Sorry for the delay.
Okay.
Now, my last slide. And for this reason, we use beta-lactam antibiotics, which are penicillin, V, and amoxicillin, and because they are wide-spectrum antibiotics. And amoxicillin is absorbed better than penicillin. It also has a much broader spectrum against the gram-negative bacteria than penicillin. And appropriate blood levels are retained for a slightly longer time. And it is often given with clavulanic acid to increase its spectrum. And amoxicillin and clavulanic acid is one of the antibiotics recommended for treatment of odontogenic infections due to its sufficiently wide spectrum and greater antibacterial effectiveness. However, it has been documented that the majority of microorganisms have susceptibility to penicillin. Therefore, it can be a good first option for the injective treatment of endodontic infections. And if you decide to prescribe antibiotics, you should start with loading doses. Recommended loading doses for penicillin are 1 milligram or administered orally, followed by 1 gram penicillin administered orally, followed by 500 milligram every 4 or 6 hours, or 1 gram amoxicillin with or without clavulanic acid, followed by 500 milligram every 8 hours. If you use penicillin, but the therapy is ineffective, the combination of penicillin with metronidazole or amoxicillin with clavulanic acid is recommended. If your patient is allergic to penicillin, there are alternatives of antibiotics which are clindamycin, clarithromycin, azithromycin. You can use both of them. Clinical improvements in symptoms must be the guide for the duration of antibiotic therapy, as we talked before. As soon as the symptoms have resolved and there is clinical evidence of healing, the antibiotic therapy should be discontinued. And usually the treatment duration of 3 to 7 days is often sufficient to control the infections, the endodontic infections. And that's the end of my presentation, and I'm really thank you for your attention.
Thank you very much, Dr. Elif.
You're always welcome.
We have many questions for you, actually, from the audience, from WhatsApp, and some other ways. But for the sake of time, we will ask the questions at the end of the presentation of Dr. Afshar, if it is also okay for you.
Okay, that's okay for me.
Okay. And so I would like to give the word to Dr. Avshar to make her presentation.
Hi guys, can you hear me? Can you hear my voice?
Yes, we can hear your voice and see your screen.
Hello and good afternoon. I'm Dr. Mahsa Afshar from Endodontics Department of Tehran Dental University. It's my honor to be a part of this program. Here I'm going to talk about endodontic flare-up, etiology, and management. I have 5 main titles, as you can see: inter-appointment and post-operation flare-ups, over-instrumentation, overfilling, hypochlorite accidents, and pain management. I want you to, the audience, to answer my questions at the end of my presentation. Question number 1, antibiotic administration is recommended for 1 inter-appointment flare-up, 2 without swelling, 2 inter-appointment flare-up and localized swelling, post-operation flare-up with a localized swelling, post-operation flare-up with a diffuse swelling in a diabetic patient, retreatment of a failed root canal treatment with a sinus tract. Sorry for the interruption. Question number 2. Which of the following could be more useful for sodium hypochlorite accident management? 1, negative pressure irrigation device such as Endovac. 2, intramuscular injection of corticosteroids. 3, warm compresses immediately after the accident. 4, finalizing the root canal treatment in 1 session. And 5, irrigation with copious amount of chlorhexidine. So first of all, we need to know the definition of flare-up. Flare-up is defined as an acute exacerbation of an asymptomatic pulp or periodicular pathogens in the form of severe pain and swelling after the initiation or continuation of non-surgical root canal treatment. It's a true emergency and it needs unscheduled patient visits and active treatment. The incidence may be from 2 to 20%, and with the average percentage of 8.4. There may be some predisposing conditions. Actually, endodontic flare-ups are more prevalent among females under the age of 20 and old patients as well. It may occur more in maxillary, lateral incisors, mandibular first molars, in preapical abscess, symptomatic apical periodontitis, preoperative pain and swelling, and in cases with large preapical lesions. Retreatment cases are also very important because they are technically much more difficult, and there is a tendency to push remnants of gutta percha and other debris into the preapical tissue. Anxiety, genetics, and sex are also important, it seems that women are at a greater risk for many clinical conditions. The causative factors of flare-ups included mechanical, chemical, and microbial factors, with microbial factors being the major and most common causes. For microbial causes, we can point to the presence of pathologic bacteria such as Prevotella and Porphyromonas species and Fusobacterium and Nucleatum, presence of virulent clonal types, microbial synergism or additism, number of microbial cells, environmental cues, host resistance, and herpes virus infection. Herpes virus has the ability to diminish the host resistance to infection, so it could be important. Mechanical causes include mainly over-instrumentation, over-instrumentation, and overextended filling material, and hyperocclusion. Chemical causes included apical extrusion of irrigants and apical extrusion of intracanal medicaments, which are cytotoxic to the host tissues. With the emphasis on microbial causes, there are some situations during the endodontic treatment that can facilitate microorganisms to cause flare-ups. These include preparation beyond the apical terminus, apical extrusion of debris, incomplete instrumentation, secondary intraradicular infections, and overextension of root canal filling material, and lack of radicular seal. So how to prevent a flare-up? During the procedure, we can use long-acting anesthetic solutions such as bupropion, or you can it would be better to complete cleaning and shaping of the root canal system in the first session of the treatment. In some cases, occlusal reduction may be necessary, especially when there is evidence of mechanical allodynia. You may need to prescribe analgesics, and you should also prepare the patient psychologically. For verbal instructions, you should tell the patient for possible discomfort and pain after the treatment. And for therapeutic prophylaxis, you may pre-treat the patient with NSAIDs or acetaminophen, and they both are very effective for reducing post-operative pain. We do not recommend to prescribe antibiotic before treatment for necrotic before treatment of the necrotic teeth because they are not effective at all. How to treat the flare-up? Reassurance is the most important aspect of the treatment. The patient is generally frightened and upset and should be told that flare-up is not unusual and it's manageable. So the very first step is to restore the patient's comfort and break the pain cycle by using long-acting anesthesia such as bupropion and analgesics. Here are all the treatment solutions for inter-appointment flare-ups in different conditions, and I'm going to explain each of them. In cases with previously vital pulp with complete debridement, actually this situation is not a true flare-up if complete removal of the inflamed pulp tissue was accomplished at the first visit. So reassure the patient, prescribe mild to moderate analgesics, check the temporary restorations for a probable traumatic occlusion, and you can prescribe intraoral or intramuscular injection of corticosteroids. In cases with previously vital pulp with incomplete debridement, the tissue remnants have become inflamed or necrotic and have become a major irritant. So recheck the working length, clean the canal with a copious amount of sodium hypochlorite, and place a temporary restoration and prescribe mild to moderate analgesics as well. In cases with previously necrotic pulse and no swelling, these cases may result in development of acute apical abscess after appointment. This abscess could be really painful because it is confined to a bone. So in these cases, open the tooth again, reclean and irrigate the canal with sodium hypochlorite. Drainage should be established if it is possible. Place calcium hydroxide inside the canal, and you can prescribe anesthetics as well for moderate to severe pain. And there is no need to antibiotics. For previously necrotic pulse with swelling, actually these cases are best managed with incision and drainage. It's better to open the canal, reclean, and place calcium hydroxide paste inside the canal. And in serious cases, you should refer the patient to the hospital for more aggressive therapy. Post-obturation emergencies. You should know that true post-obturation flare-ups are infrequent, so there is no need to active intervention, but inform the patient about the possible discomfort after the obturation and mild level of pain which results spontaneously. So you may need to prescribe mild to moderate analgesics, but in cases when the previous treatment seems inadequate, retreatment is indicated. In cases with acute apical abscess and uncorrectable inadequate root canal treatment, apical surgery is required, and when the root canal treatment is acceptable but there is local swelling, incision and drainage should be performed. Here you can see all the treatment options to manage inter-appointment and post-obturation flare-ups in brief. As I mentioned before, you may need to re-instrument in some cases. You may need to place intracanal medicaments in some other cases, such as calcium hydroxide, corticosteroid compounds, such as leather mix and SAIDs, and so on. In some cases, you may need to perform incision and drainage. Incision and drainage facilitate the evacuation of pus, microorganisms, and toxic products, and it allows for the decompression of tissue pressure and provides significant pain relief. Occlusal reduction may be necessary in some cases. As I told you before, it relieves occlusal stress from the periodontal ligaments, and it is necessary in cases when there is sensitivity to percussion in vital tooth with a history of pain and absence of periapical radiographic lesion. You may need to prescribe drugs such as antibiotic and non-narcotic analgesics, antibiotics. I should point to this point. I should point out that in cases with local swelling and when a sinus tract is present, there is no need to antibiotics. But in case of sporadic infection or medically compromised patients, you should prescribe antibiotics as well. You may need to use long-acting local anesthetics. They block C fibrinose receptors and decrease the potential for central sensitization, so they can provide an increased period of post-treatment analgesia. And in some cases, you may perform retreatment or periapical surgery. Now I'm going through the next title, which is Overinstrumentation. I'm going to explain the etiology at first. A lack of or incorrect determination of canal length are the most common reasons for overinstrumentation. Other causes may be attributed to incorrect positioning of the silicone stoppers and inadequate observation of the reference points. How to prevent overinstrumentation? Recognition of the importance of correct instrumentation length is the key to avoiding overinstrumentation. Proper choice of radiographic technique, as well as together with careful observation of the radiographs, is really important. Repeat the radiographs if the difference between the instrument position and correct working length is more than 2 to 3 mm. And finally, the use of apex locator is really valuable for maintaining correct working length. Oral instrumentation with small files often remains unnoticed. However, there may be a copious bleeding into the canal, usually continuing the instrumentation with copious amount of irrigation with sodium hypochlorite results in cessation of the bleeding. Repeated over-instrumentation, especially with larger instruments, result not only in bleeding and periapical damage, but also in destruction of the apical foramen. This in turn makes it more difficult to obtain a good apical seal. Iatrogenic over-instrumentation promotes the enlargement of apical foramen, which may permit an increased influx of exudates and blood into the root canal. This will enhance the nutrient supply to the remaining bacteria within the root canal, which can proliferate and exacerbate the situation. So for the treatment, depending on the magnitude of the damage, short or long-term calcium hydroxide treatment is recommended following over-instrumentation, and in some cases, there may be a need for NTA placement. Overfilling is the next title that I'm going to talk about. The extrusion of the root filling material beyond the radicular foramen or the perforation site may occur either when the canal is obturated or during the removal of obturation materials. Extrusion of filling material may be associated with the post-treatment inflammation, flare-up, and lack of radicular healing. We can see that the most favorable outcome when the root filling material remains within the radicular constrictions. And for gutta percha, when it's extruded into the perradicular tissue, there can be a severe inflammatory reaction, but MTA and other calcium silicate-based cements and sealers are much more biocompatible and do not seem to produce much perradicular inflammation in case of overfilling. Uncontrolled obturation can cause the extrusion of the root canal filling material into the maxillary sinus or into the territory of inferior alveolar nerve, as you can see in the pictures, which may result in serious complications such as maxillary sinusitis, aspergillosis infection, orbital pain and headache, or paresthesia and dysesthesia. What is the etiology of overfilling? Overextension of the root canal filling material occurs mainly for lack of material control, which includes accidental over-instrumentation and incorrect canal working length measurements. Preparation techniques may also be an etiologic factor. The more continuously tapered the canal shape is, the less obturation material is extruded. Obturation technique is another important factor. Warm vertical compaction and carrier-based obturation techniques result in more extrusion, and you should avoid uncontrolled condensation forces. Degree of maturation and larger minor foramen diameters are also important, so you should be cautious in cases with open apices and apical root resorption. How to avoid overfilling? Tapered preparation with an apical matrix usually prevents overfill. The largest file and master cone at working length should have a positive stop. A customized master cone may be fabricated or MTA plug may be placed. And if overfilling is suspected, a radiograph should be made before excess gutta percha is removed. Where the canal filling material extends into the perradicular spaces, tissue damage may occur. In majority of these cases, we just need to follow the patient. We also may prescribe analgesics, cold packs, and corticosteroids to decrease perradicular inflammation caused by a foreign body, and even in some cases antibiotics when signs and symptoms of endodontic failure appear, non-surgical or surgical treatment may be required to remove the material from apical tissues and place root and filling material. The long-term prognosis of overfilling is dependent on the quality of the apical seal, amount and biocompatibility of extruded material, post-response, toxicity, and sealing ability of the root canal, root and filling material. The next title is sodium hypochlorite accident. As you know, sodium hypochlorite is an effective irrigant which has some advantages and disadvantages. It can disrupt the biofilm, dissolve necrotic tissue, and remove organic components of the smeared layer. However, it is extremely cytotoxic, lethal to fibroblasts, and its tissue injection can result in hemolysis, ulceration, endothelial and fibroblast cell damages, and neutrophil migration inhibition. What are the probable causes of sodium hypochlorite accidents? The majority of the reported accidents seems to be due to an inaccurate working length, forceful injection of the irrigants, and wedging of the irrigation needle. It can easily occur in teeth with large apical foramen, apical resorption, or immature teeth. Iatrogenic widening of the radicular foramen and lateral perforation of the root can also result in hypochlorite accident. Sodium hypochlorite accidents happen more commonly in maxillary posterior teeth diagnosed with pulp necrosis and preapical lesion. The initial patient reaction to hypochlorite accident is severe and immediate pain, with marked edema or bruising that may extend over the time. There may be spontaneous and profuse hemorrhage. In the case of maxillary posterior teeth, patients may also report preorbital pain, calorie taste, and irritation of the throat. Pasteria, either transient or permanent, can occur, especially if interventional treatment is not rendered immediately. Motor nerve dysfunction secondary to chemical damage can also occur. Increasing edema can be dangerous in mandible as it compromises the airway. And finally, secondary infection could also happen. How can we manage sodium hypochlorite accident? At first, we should stop further treatment. Then with the emphasis on pain control, local anesthetics and analgesics can be administered. Immediately irrigate the canal with normal saline to encourage bleeding. Bleeding can both dilute and remove sodium hypochlorite from the site of the injury. Using a negative pressure is very helpful for irrigation. Applied cold compresses. It can moderate swelling and edema. After 1 day, apply warm compress to stimulate the local microcirculation. Antibiotics are usually prescribed, but the use of corticosteroid is equivocal. There should be a balance between the spreading edema and the increased risk of infection. And do not forget to monitor the patient and reassure him. How to avoid sodium hypochlorite accidents? Establish an accurate working length and place a rubber stop on the irrigation needle shorter than a working length. Avoid over-instrumentation of the radicular foramen. Employ a small side-vented needle. Express the fluid slowly and observe that it is venting through the access cavity. Carefully assess the canal integrity. Avoid wedging the needle tip or inserting it beyond or at the working length, and move the needle up and down. Confirm the identity of the solution prior to irrigation. The last title of our presentation is about analgesics and pain management. Management of endodontic pain is multifactorial and directed at reducing the peripheral and central components of hyperalgesia and allodynia through combined endodontic procedure and pharmacotherapy. Non-narcotic analgesics include both NSAIDs and acetaminophen. NSAIDs are very effective in managing pain of inflammatory origin. They bind to plasma protein and their delivery to inflamed tissue increased via the extravasation of plasma proteins. They produce analgesia through both peripheral and central mechanisms. Actually, they inhibit the synthesis of prostaglandin by blocking cyclooxygenase, which has two isoforms, COX-1 and COX-2. COX-1 has a variant called COX-3, which is expressed predominantly in the CNS, and this is where the central mechanism of the analgesia comes from. Numerous NSAIDs are available commercially, and you may know many of them. For example, ibuprofen has a well-documented efficacy and safety, etodolac, ketoprofen, ketorolac, and diclofenac. The advantage of NSAIDs is, in general, include the well-established analgesics efficacy for inflammatory pain, and they have been shown to be more effective than acetaminophen and opioids combination. Acetaminophen is another non-narcotic analgesics. It exerts its effectiveness by inhibition of COX-3 in CNS, and according to recent studies by some active metabolites which affect CNS cannabinoid receptors and blood calcium channels. Acetaminophen alone is not comparable with ibuprofen in relieving moderate to severe pain. However, a combination of both provides greater pain relief than either drug alone. There are some limitations and drug interactions. For NSAIDs, NSAIDs exhibit an analgesic ceiling that limit the maximal level of analgesia. They also have some gastrointestinal and CNS side effects. They may be a cardiovascular risk with some. There may be a cardiovascular risk with some NSAIDs. They can increase PT time or bleeding with anticoagulants, and they can reduce antihypertensive effectiveness of some other drugs. NSAIDs are contraindicated in some patients with ulcers, aspirin hypersensitivity, asthma, renal insufficiency, gastritis, bleeding, diabetes, patients with allergic reaction who have undergone coronary artery bypass graft surgery, and during the third trimester of pregnancy. So in these patients, acetaminophen should be considered. However, acetaminophen causes a liver toxicity, and it is less effective than ibuprofen, and its maximum dose per day is about 3 grams. Now we are going through opioid analgesics. They're potent, as you know, and often used in combination with acetaminophen, aspirin, or ibuprofen. They activate more opioid receptors in the brain and on afferent fibers. They are effective as analgesics, but they have no anti-inflammatory effect. They have some adverse effects such as nausea, emesis, dizziness, drowsiness, and respiratory depression and constipation. Corticosteroids. Post-treatment pain or flare-up could be attributed to inflammation, infection, or both. Establishing patency and the cleaning shaping during a root canal treatment may irritate the perradicular tissues and inadvertently introduce bacteria, their products called tissues, or irritants through apical foramen. In response to these irritants, inflammatory mediators are released. As a result, pain fibers are directly stimulated or sensitized, and an increase in vascular dilation and permeability results in edema and increased interstitial tissue pressure. Corticosteroids have the ability to reduce acute inflammatory response by suppressing vasodilation, the migration of polymononuclear leukocytes and phagocytosis, and by blocking COX and leaf oxygenase pathways and synthesis of prostaglandin and leukotrienes. Corticosteroids can be used local or systemic. Local administration like leather mix and in this, which is a combination of triamcinolone and democlocycline, and is completely effective in reducing post-operative pain. Systemic administration like supraperiostal, intraosseous, or intramuscular injection or oral administration, and it's been proven that systemic administration of corticosteroids are effective, but they're not the first choice given the relative safety and efficacy for management of pain. So be cautious in cases of spreading infections. And finally, pain management strategies. Effective management of endodontic pain starts with 3 Ds: diagnosis, definitive dental treatment, and drugs. In the management of endodontic pain, the main focus should be put on removal of peripheral mechanisms of hyperalgesia and allodynia, which are main treatments such as pulpotomy and pulpectomy, plus pharmacotherapy to reduce continued nociceptor input and suppress central hyperalgesia. As I mentioned before, 3Ds pain control includes diagnosis, definitive dental treatment, and drugs. For drugs, we can pre-treat the patient with NSAIDs or acetaminophen. The rationale for pre-treatment is to block the development of hyperalgesia, but by reducing the input from peripheral nociceptors. We can also use long-acting local anesthetics, long-acting local anesthesia such as bupivacaine, not only provide anesthesia during the procedure, but also delay the onset of post-treatment pain. We can use a flexible plan, which I'm going to explain later. And it's advisable to have endodontic patients take their analgesics by the clock rather than as needed basis. If they wait to take the medication after the initiation of pain, there is usually a delay of up to 1 hour before pain relief. And here is the last slide, which is about the flexible plan. Flexible plan strategy minimize both post-operative pain and side effects. So there are 2 goals. The first one is to achieve a maximally effective dose of the non-narcotic analgesics, either NSAID or acetaminophen. And the second goal is to consider adding drugs or opioids that increase analgesia in rare cases of moderate to severe pain. As you can see, we have 2 columns. NSAIDs for management of pain. In mild pain, we can prescribe ibuprofen or aspirin. And in cases which NSAIDs contraindicated, we can use acetaminophen. For management of moderate pain, we can prescribe ibuprofen again and acetaminophen or a combination of them. And in cases when NSAIDs contraindicated, we can prescribe acetaminophen again with a combination with codeine. And in severe cases, we can prescribe ibuprofen plus a combination of acetaminophen and oxycodone. And in cases when NSAIDs contraindicated, we can prescribe a combination of acetaminophen and oxycodone again. And thank you for your attention.
Thank you very much, Dr. Avşar, and thank you very much, Dr. Başarcan, for your great presentations. They were very useful and informative. There are some questions from the audience. I would like to ask them in advance.
Professor Kazandak, before you go further, I want also to thank these two ladies for their very, very marvelous presentation. First of all, from Professor Elif Başarcan, if I pronounce her name correctly. Is it correct? Başarcan?
Yes.
Okay,
Başarcan.
great, great. And her first name, Elif, means a lot to us because it is the first alphabet in our language. And it shows that we want actually to communicate with each other. The best way for communication to write and to speak and make this network with each other. And thanks to Puyan Amini Shakib, who did this great networking between us. Now, our friendship with Professor Kazandak, that I prefer to call her Meriç rather than Professor Kazandak, because she's a very close friend of mine. I think our friendship now goes back to more than 15 years. But now I'm very proud that between our universities, we have an amazing network. And now we can say that Yeditepe University and Tehran University of Medical Sciences School of Dentistry are sisters. More than two universities. We are two sister universities. We are two sister universities, and we are very proud for working to each other. By the way, thanks to all of you, and also thanks to Dr. Afshar. She is one of our young fellow, and we are very proud of her as well, because I remember that around 3 years ago, she passed the board exam of endodontic board exam of Iran, which is a very, very, very difficult exam. I remember that I couldn't pass it on the first time, and I actually did that twice to get the board. But Dr. Afshar surprisingly gets 100 out of 100 in this exam. So she was one of the very, very exceptional students of us, a postgraduate student, and now she is one of our assistant professors. We are very happy to have her. She is one of our talented fellows in Iran, and now we can say that this network actually becomes better and better. Thank you very much, all of you. Meriç, thank you very much for that. And I think we need also to thank Professor Baber Kayahan, because he is not here with us, unfortunately, because I know that he's not working anymore with Yeditepe University. But all of this friendship based on his very, very big heart, and this networking start by his actually initiation. So thanks to him as well. Please pass my hello to Professor Mehmet Baber Kayahan, and hopefully we can increase and expand our network to other universities and other friends to become stronger and stronger. Thank you very much, all of you.
Thank you, Dr. Nekofar.
Thank you, Dr. Nekofar, for your nice speech. I also would like to thank to the deans of the both schools. They supported us by all means. And also sincerely would like to thank all the department chairs and the moderators for supervising the speakers. And I would like to express my sincere appreciation to the participants, especially the students who supported the meeting with their questions and energy. I think this meeting was blessed by their existence. And there are some questions, Dr. Nekofar, from the audience to the speakers. Shall I ask them?
Yes, please, go ahead.
Okay. For Dr. Delve, Dr. Başarcan, at what point do endodontists recommend the extraction of the abscess teeth?
It's a difficult question. And if the bone level is sufficient and if there are no periodontal problems. And of course, if we can restore the teeth properly, and with endodontic therapy, you will solve the problem. But in cases with periodontal problems, with insufficient bone levels, then maybe extraction can be. I hope that's enough for the answer, I think.
Thank you very much. And the second question for you again. At the beginning of your presentation, you gave information that the concentration of the hypochlorite, which we routinely use in treatment, is between 5 and 6%. Considering the fact that the toxic effect increases as the hypochlorite concentration increases, should this concentration change according to the severity of the periodontitis, or whether there is a pulp necrosis or not? About this, is there an accepted standardization about the concentration by pulp pathology? Thank you very much, says the audience.
And we are talking about emergency cases, and when an emergency patient comes to our clinic, we usually in the middle of another treatment with another patient. So we have limited time, and our primary goal in emergency cases is to remove infected tissue, necrotic tissue, as much as possible in a limited time. So we need strong agents, and studies show that 5.5 or 6% sodium hypochlorite is effective on biofilm elimination. So we need high levels of sodium hypochlorite in emergency cases because we have time limitation, time constriction. In your daily practice, you can use 1% or 2% sodium hypochlorite with sonic or ultrasonic agitation in longer periods. But in emergency cases, you should use full strength sodium hypochlorite to remove the necrotic or infected tissues from the canals.
Thank you very much.
You're welcome.
And some questions for Dr. Afshar. Do you recommend utilization of electronic apex locator alone for the working length determination to prevent complications?
Would you please repeat the question? I didn't get the first part.
Do you recommend using electronic apex locator alone? Does it matters in terms of preventing complications?
Actually, using apex locator alone is more accurate than radiograph alone. So,
Dr. Afshar, the quality of your voice is not very good. If you come closer, maybe it become better.
okay. Apex locator alone is more accurate than radiograph images alone. But in most of the cases, I prefer to combine using radiograph and apex locator together.
May I add something?
Yes, of course, please.
Okay, first of all, thank you very much from our students that they turn on the videos, because we feel now we are in a classroom or in a conference room, we can see each other, we can communicate easier. So maybe it's a good idea if everyone turn on their videos. And secondly, about the use of apex locator alone, Dr. Afshar, I think it depends on how familiar us with the electronic root canal length measurement devices or apex locator.
Yes, there may be some.
Because sometimes we are not familiar how to use it, so it ends up with some incorrect result. However, after get some sort of experience and we get used to that, I prefer to say that when we understand the language of the apex locator, we can trust them. Because with radiograph, as you mentioned, Dr. Afshar, 60% of cases are just correct. And with apex locator, it is more than that. It is around 90%. But it depends on a lot of limitation of this device. Maybe Dr. Shakib should invite us again and arrange another meeting to speak about apex locator. Why not? So let's be ready for the next session speaking about electronic apex locator. I'm happy to do that for you.
Thank you. I think this is a very good idea as well. And one more question for Dr. Afshar. What do you mean by long-term calcium hydroxide medication following the over-instrumentation? So 1 week, 2 weeks, a few days, what do you mean by long-term?
Long-term calcium hydroxide, it was a suggestion, but it's actually now with the use of with MTA. I honestly, I myself do not recommend the long, usage of calcium hydroxide. You can just put the MTA at the end of the canal, place an MTA, place an MTA plug, and no worries.
Thank you very much. And one more question for you again. The audience is highly engaged. We appreciate that. If we, during choosing master apical cone for the canal, and accidentally the gutta-percha became over, and during getting out from the root canal, unfortunately a part gutta-percha stick here, becoming periapical. In this condition, what should we do? And if we leave it, what possible problems may happen to the patient or for the treatment?
Okay. First of all, as I mentioned in my presentation, just follow up the patient for a month or even 3 months. Most of these cases show the healing process without any problem, but you may need to prescribe much moderate analgesics, as I told you before, or even low doses of corticosteroids may be beneficial in some cases. But when there is no signs of healing, then you may need to retreat the tooth, and even in some cases you may need to perform apical surgery to remove that part of gutta-percha.
Thank you very much. Are there any questions for Dr. Asedian or Dr. Taner?
Excuse me, could you please repeat?
I asked the audience if there are any questions for you too, for Dr. Asedian and you. I think there are not any questions. So I'm sharing the award link for award competition in the chat box. Everybody is welcome to take an exam. We have very nice awards, and the winners will be announced in the web pages of the universities tomorrow. First come, first serve based is also will be one of the principles for award competition. And you're all welcome, Dr. Nekofar. I want to give you the word, maybe, and Dr. Shakib, and if anyone who wants to talk about this meeting.
Thank you very much. I want just to say thank you to all of the nice words that in the chat box our amazing participants and students sent to our very nice presenters. First of all, Professor Tanalap, obviously, Jale is one of the best. I'm not saying it just in Turkey, in the world. She has got an international view everywhere, so we know her very well, and obviously it was great to have her, and all of our young lecturers as well. Thank you very much to all of you. I can't read all of these nice words for you, and I'm personally very proud, so congratulations to all of you. And thanks to both universities for arranging that. I was in a part of that, and I was witness a huge amount of the time that this gentleman and gentlewomen spend to arrange this meeting. It's not very easy to do such a thing. So thank you all for all of your effort, and I'm sure everybody appreciate your effort, and hopefully we can see each other again and again. And I think Dr. Shakib is very keen to take a group photo. So now we have, I think, 12 of you or 13 of you with us. Whoever happy to be with us may say hello and goodbye again to each other and prepare ourselves for this final group photo.
Thank you.
Okay, thank you very much.
Thank you. Thank you. It was a great honor for us to have you all from Yeditepe University and also from Tehran University. A great gathering, scientific gathering. Thank you very much.
Thank you for everything.
Goodbye, everybody.
Bye-bye.
Bye-bye.
Goodbye, everybody.